Um, Welcome everybody to our winter quarter weekly seminar series for the Center for Healthcare Policy and Research. Happy New Year. I think some people are still getting back into work this week after hopefully some time off over the holidays. This weekly seminar series is co-directed by Dr. Jeff Hotch and myself in the center, and also supported by Bill Daler here. So many of you know us, but just reach out to any of us if you have any questions about our overall approach for this quarter. Um, just to remind you, as since we're at the beginning of the quarter, we really are trying to showcase applied and health services research relevant to all three missions of our center in terms of educational work, policy practice work, and research and methodological innovation in the applied and health services research space through our seminar. And so we're kicking off this month, and we're really thrilled to have Dr. Robert Ellis, who I'll introduce in 1 minute for today's seminar. But first, we had an update about our new medical CME education system for those of you who want CME credit for participating in this seminar. That Bill is going to just spend a second talking about, and there's instructions on the screen.
Sure. So the new system is Cloud CME, and there are 3 ways to claim credit. One is to text the activity code you see here to the phone number shown right here. You have to opt in for text messaging first. So again, just use that number, and your home department should have helped you set up your profile. So if you have any questions, please refer to your home department. The second one is to use the mobile app. This QR code does not work with your camera. You need to open the mobile app and then scan the QR code. That is the second method. Those are the 2 preferred methods, I'm told. I'm told the one you can use, but they don't suggest, is to log directly onto the CME website and use the activity code there. So that's not on the slide because it's not suggested, but is another possibility if the other 2 aren't working for you. So just let your home departments know if you have any questions.
Thank you. Yeah, I wanted to spend a minute on that today since it is new, and then we'll put that slide back up at the end of today's session and future sessions as well. Not all of you are taking it for CME credit, but just for any of you that are, don't want you to get confused given the changeover in the system. Okay, so we're super thrilled today to have Dr. Robert Ellis speak to us about some of his really amazing work in health services research and specific to alcohol use and improving both behavioral healthcare, but also physical healthcare from a variety of perspectives. So I wanted to introduce Rob to say that he is a postdoctoral scholar with us at CHPR for the past about 8 or 9 months here at UC Davis. He previously got his PhD at the University of Washington in, I want to get the name right since they changed it, Health Systems and Population Health, used to be called Health Services Research in the School of Public Health at the University of Washington. He also holds a master's in health administration from Columbia. And so he has a lot of experience across multiple sectors of healthcare. And I'm really excited that he's with us. If you haven't met Rob yet, he's amazing. And he's going to share with us a little bit about some of his dissertation papers and where he's headed in his career. So thank you, and take it away.
Thank you for that wonderful introduction. I'm going to share my screen now. So please let me know if you can see.
We are good.
Okay, sounds good to me. Thank you again, Courtney, for that introduction. Again, my name is Rob. I'm a postdoctoral scholar at the Center of Healthcare Policy and Research at UC Davis. And first, I do want to start by saying Happy New Year. And I hope everyone has a great year. I know you could be anywhere doing anything, and I'm just grateful that you are here just listening to what I have to say about my research that looks at assessing diagnosing patterns of alcohol use disorder. We'll be saying AUD throughout this presentation. So AUD, alcohol use disorder, in primary care settings across intersecting identities as it pertains to the role of screening tools such as the AUDIT-C as well as the Alcohol Symptom Checklist. And so I want to thank our funders, specifically Kaiser Permanente Washington Health Research Institute, where the data set, where I did my dissertation work at, as well as a lot of support for this study came from. And I also want to state that I have, and we have, the authors have no financial or other conflicts of interest. and the views expressed in this presentation are those of the authors. I also want to say some presentation goals include talking about some preliminary knowledge of AUD in the primary care settings, as well as discussing some intersectionality theory applied to health services research. And lastly, talking about some of the implications of AUD screening tools, such as the AUDIT-C and Alcohol Symptom Checklist. And this roadmap kind of highlights the journey that we'll be going on today. And so we'll talk about some of the background stuff, as well as describe the setting, go through the aims, and go through key findings and implications, and we'll save time for the questions at the end. And so getting right into it, here we're going to go into our background. And so unhealthy alcohol, including AUD, contributes to 2.8 million deaths per year globally. That's around 4.5% of all deaths. And it's the 7th leading cause, leading risk factor for death and disabilities. And it damages health broadly, including organ damage, injuries, accidents, many of us know like car accidents, mental health, et cetera, et cetera. And it disproportionately impacts individuals from marginalized and minoritized communities. And if you look to the right, you will see a graph, and it says specifically the US, 70% of the population consumes any alcohol use in a given year, and 27% consumes alcohol at risky levels. Later in the presentation, we'll talk about what that risky levels means. And actually around 10% of the US population has AUD, and that 10% can be broken up into 6% mild AUD, 2% moderate AUD, and 2% severe AUD. Moreover, in the clinical settings, AUD is often underdetected, with only around 22% of people with AUD being diagnosed in the clinical settings. It's also a space where there's a lot of undertreatment, with only 8% of the patients with AUD receiving evidence-based treatment. And there's a lack of standardized assessment using valid and reliable instruments. Now, this is particularly important because in the primary care settings, you have brief interventions, behavioral therapies, medications, and a host of other evidence-based treatments that can be offered. In addition to that, most people, regardless of their race, ethnicity, sex, or any intersection of identity, and also who consume alcohol at these risky levels, or even have AUD, they use the primary care services. Hence why primary care presents a major opportunity to equitably address alcohol-related care in general. And so I like throwing this slide up because it kind of like, I like setting the tone for what an ideal world would look like in this case. And so in an ideal world, a patient with AUD, regardless of their race, ethnicity, sex, or even intersecting identity, would have their AUD detected during their primary care visit. It would be properly documented and equitably diagnosed, and the patient will receive affordable and accessible evidence-based treatment. However, the reality is that AUD has a stigmatized history, and the healthcare landscape in the United States is far from ideal for addressing AUD. And so, in addition to, I guess, go into more detail about AUD and the stigma, it is one of the most stigmatizing mental health conditions. And treatment for AUD has been heavily stigmatized as well, and it has historically taken place outside of the healthcare system. It takes place in places like Alcohol Anonymous and other religious groups or religious settings. Further, there are systemic barriers that, such as limited access, resource constraints, and discrimination that cause marginalized individuals to be documented with stigmatized conditions in general, like AUD, at higher rates, while at the same time experiencing worse health outcomes and having limited access to the effective treatments for those stigmatized conditions. And so we have advocates and researchers, and it kind of stemming from this Black feminist movement, suggesting that these forms of discrimination actually overlap, creating what is called intersectional discrimination. And intersectional discrimination or intersectionality captures the nuances often missed in research that focus on either race or sex alone. For instance, a Black patient who is from a lower socioeconomic status may have a different experience than, say, a Black, well, let me rephrase, a Black woman patient from a lower socioeconomic status may have a different experience than maybe a white woman from a higher socioeconomic status. And therefore, to move towards equitable treatment for AUD in primary care, a critical first step is ensuring that we have equitable diagnosis of everyone. And going into, I guess, trying to get into more detail of why this bias may exist, particularly in the clinical setting versus, say, national surveys. Well, in a national survey, there's a bit of, you just taking a survey and it's usually in a private setting versus in a clinical setting. There's a host of reasons why you may be there. You may be court ordered to be there. And also, I know the information in those clinical settings shouldn't necessarily get out, but oftentimes they do. And so it may encourage patients to, on the patient side, to not necessarily disclose as much information as possible, but also influence bias on the provider side themselves. And also in the clinical setting, the AUD diagnosing cascade is not necessarily as seamless as it may be in like a survey mode, but because it's in a real world clinical setting, it happens on a diagnosing cascade. And so what that essentially means is, for example, the lower end of this cascade, a person may drink at an unhealthy level. They may develop AUD symptoms, they may not develop those symptoms. They may not report those symptoms for various reasons. Maybe they experiencing racism inside of the healthcare system, or a host of other perceived stigma or environmental factors. Provider recognizes and detects AUD in certain individuals versus others. That may be from provider bias. That may be from a host of other reasons why providers may see AUD in some people and may not necessarily recognize it in other people. And lastly, a provider is selecting the descriptors to document AUD. So the provider documenting the AUD even if they recognize it. And so this entire cascade is privy to disparities and bias that can happen at several points in this cascade. And AUD diagnoses are not necessarily assessed in a standardized way. And when providers are presented with limited information, they may either present overt or covert bias when diagnosing patients with stigmatizing conditions such as AUD based on a patient's race, ethnicity, sex, or intersection of those identities. And therefore, our study sought to assess AUD diagnosing patterns in EHRs in the real world primary care setting using intersectional lens. Now we're going to describe the setting of this study, and that is at Kaiser Permanente, Washington. Kaiser Permanente, Washington, and I will refer to it as KPWA for short throughout this presentation, is an integrated health system that provides health insurance as well as medical care to over 350,000 patients throughout its 35 primary care sites. And all the clinics use the integrated health electronic health records. And around 2015, KPWA began to integrate alcohol-related care in primary care settings. And it goes as following. The primary care patient completes the annual behavioral health screening that includes the AUDIT-C. And in future slides, I will show you in a large picture of what the AUDIT-C looks like in case you have never seen AUDIT-C before. And if you engage in risky drinking, is detected on this AUDIT-C, and that means like a AUDIT-C score of 3 for women and 4 for men. A handout is given to providers as a prompt for brief intervention. And lastly, if you are if you consume alcohol at a high-risk drinking level, and that is detected by the AUDIT-C, and that equals a AUDIT-C score equal to or greater to 7, a DSM-5 AUD criteria are assessed using the alcohol symptom checklist. And this alcohol symptom checklist, it mirrors what is the survey that is done in those national surveys that we talked about earlier. And bringing that survey inside of the clinical setting is something that's unique to KPWA. And so, as promised, here's the enlarged version of the AUDIT-C, which is, again, a part of that annual behavioral health screening. And it goes on a score from 0 to 12, and it measures alcohol consumption. And this is an enlarged version of the alcohol symptom checklist. It is a new measure developed by KPWA, and again, completed by patients with the AUDIT-C score greater to or equal to 7. So again, if they have an AUDIT-C greater to or equal to 7, it pings in the EHR that the provider should therefore give them the alcohol symptom checklist, and then that's how they have opportunity to complete the alcohol symptom checklist. And again, all 11 items are modeled after the 11 DSM-5 AUD criteria. And it was originally designed to help providers engage with patients in a discussion about alcohol use and related concerns, because it measures the symptoms as well as symptom severity. And it can also aid in making more specific AUD diagnosis, because it can be broken into the 4 categories, which is 0 to 1 means no AUD, 2 to 3 is mild AUD, 4 to 5 is moderate AUD, and 6 to 11 is severe AUD. And now we're going to discuss the aims. And so in aim 1, which includes patients who completed just the AUDIT-C. So this is going to be a larger sample size, because it's just including the people who took the AUDIT-C screening in their annual behavioral screening. And for this aim, we describe patterns in the prevalence of documented AUD in the EHR among primary care patients across intersections of race, ethnicity, sex, and neighborhood SES. And in aim 2, it includes patients who completed both the AUDIT-C as well as that alcohol symptom checklist, which is going to be a smaller population, a smaller sample size, because it is the people with, who engage in high-risk drinking. And so we assess the differences in documented AUD across race, ethnicity, and sex in health systems that routinely screen for alcohol consumption as well as the AUD symptoms. And so aim 1 has been published. Again, it is a cross-sectional study that describes the patterns of prevalence of documented AUD across the intersection of race, ethnicity, sex, and SES. And so the study sample is going to be large. Again, 439,375 primary care patients. The inclusion criteria includes 18 or older, had a primary care encounter from March 2015 to September 2020, had an alcohol screening via the AUDIT-C documented in the EHR on the same date or within the prior year of the index visit, and were documented as Latina, Asian, Black, Native Hawaiian, Pacific Islander, or I'm going to refer to it as NHPI, American Indian, Alaska Native, or AIAN, or white. And if more than one encounter was eligible for a patient, one was randomly selected at the index encounter. The outcome for this aim is going to be provider documented AUD based on ICD codes, leaving 1 year for follow-up. The predictive variable is a categorical variable representing 2 sets of 18 subgroups reflecting the intersections of race, ethnicity, and the terciles of neighborhood SES for women and men separately. And the reason why we wanted to stratify in our analysis is because we're taking people who took that AUDIT-C, but that's a huge range of people who may consume no alcohol all up to maybe at high risk levels of alcohol consumption. And because there's an inherent, the research has shown that men and women consume alcohol at different levels, so we wanted to make sure that we accounted for that. And including these predictive variables, it includes the 6 mutually exclusive races or ethnic groups extracted from the EHR, Again, the three terciles of neighborhood SES, and I'll refer to it as SES throughout the slide, and two sex groups that, due to limitation of documentation, could represent either sex or gender identity in this study. And so again, analysis was conducted at the patient level, and it was stratified by sex to account for the sex-related differences in alcohol consumption. We described the demographic and clinical characteristics overall and across racial and ethnic subgroups. We used logistic regression to estimate the association of the intersectional subgroups, which is the predictive variable, and the provider documented AUD, which is the outcome variable. We use a proportionally weighted marginal standardization procedure to estimate the prevalence in a 95% confidence interval of provider groups, with the provider documented AUD for each subgroup. And so here's our table 1 for AIM-1. And let me orient you to the table. At the top, we have racial and ethnic groups. And you also see that, again, it is stratified by women at the top and then men at the bottom. And on the sides, we have the vertical left side, we see that we have the characteristics that we're discussing, which is the terciles of SES. And right off the bat, we see that white patients made up majority of the sample, around 75% of the sample for both women and men. And if you look at the terciles of SES, which is going to be those boxes, we'll see that Asian and white patients had a more balanced distribution of patients at each terciles of SES, and they are highlighted in the black. You will see that actually in those boxes that there's a higher, a high distribution of patients in the highest tercile versus the lowest. Now you'll see the opposite trend when you're looking in the red boxes with the other racial and ethnic groups. And particularly, we see that Black patients, Black women had the highest proportion of patients with the lower SES, which is going to be 52.9, and this pattern is similar among Black men, which 49.1. And so our main model shows the prevalence of provider documented AUD in 95% confidence interval among primary care patients across intersections of race and terciles of SES, again stratified by sex. And the sex and SES terciles, again, are at the top. And the race and ethnicity are on the side. Our main analysis was unadjusted to see the real-world prevalence of provider documented AUD, and the overall prevalence was 1% and appeared to vary across intersections. And for both men and women and men of all racial and ethnic groups, provider documented AUD appeared to be similar across the terciles of SES. And so essentially what that means is Latina, for example, you will see if you look at the lower, middle, and high, it is very similar across. And there was no consistent patterns of which tercile was higher or lower. And this was reflected in all of the racial and ethnic groups. However, for both women and men, Asian patients appear to have the lowest prevalence of documented AUD compared to other racial and ethnic groups, as indicated by the red boxes versus the other. Regarding intersectional subgroups, among women, Asian women with middle SES appear to have the lowest prevalence compared to American Indian Alaska Native women with middle SES. So you see here, Asian women. And among men, Asian men with high SES appear to have the lowest prevalence compared to AN with middle and high SES. Of note, many of the confidence intervals were overlapping And so we picked out the highest and lowest here. And so there are limitations to our study. The EHR, first, the EHR ascertaining race, ethnicity, sex, and neighborhood SES cannot fully capture the multiple factors that influence how much a person is exposed to or experiences structural discrimination associated with intersecting identity. And also, kind of like what we were talking about at the beginning of the presentation, a lot of substance use and particularly alcohol use is taking place outside of the healthcare system. And so by excluding the external claim data from the AUD or not having it, the providers provided AUD diagnosis provided by clinicians in the community, as well as like some of those other religious groups or maybe even other sources, it may have reduced the prevalence of provided documented AUD observed in the study. And then, as well as Kaiser Permanente Washington is an integrated healthcare system, which is again a region located in the northwest part of the United States and has a majority insured and white population. And so some of the key findings, just to wrap this aim up, is there were no consistent patterns across terciles of SES within subgroups of race, ethnicity, and sex. The overall prevalence of AUD was 1%, and it varied across intersectional race, ethnicity, and sex and terciles of neighborhood SES. And this is very low compared to the 10% prevalence we talked about in the national studies. And it is also low compared to the past VA studies that kind of also looked at AUD in clinical settings, which found the overall prevalence to be around 6.5%. And there are major differences between this population, or non-VA population, and a VA population, or even a non-VA environment, a health environment versus a VA health environment that may can explain some of those reasons. And with the exception of AI and AEN patients, white patients had a higher prevalence of documented AUD compared to minoritized racial and ethnic groups. And the reason why this is important is because in the national surveys, you find that white people report having higher AUD than, say, marginalized groups. But in the VA studies, we found that that is actually the inverse, that who is being diagnosed at a higher rate with this stigmatizing condition or AUD is going to be marginalized individuals, minoritized individuals. However, our study kind of reflected what happens at the national level in terms of white patients having a higher prevalence than, say, Black patients. However, again, it was still overall the prevalence was still very low, contrasting to both the VA as well as the national survey. And so some implications are the findings of this study show variation. It does show variation in documented AUD, and not shown in this presentation. These variations persisted in models that was even adjusted for each score of the AUDIT-C. And this has become even more important when we talk about AIM-2. And secondly, no study to our knowledge dives this deep into the intersection of race, ethnicity, and SES regarding substance use and alcohol use disorder specifically. And these findings and methods can set the stage for future studies looking to evaluate medical conditions, stigmatized medical conditions in EHR across intersecting identities. And so now we're gonna go into AIM-2, which is currently under review. And it is a cross-sectional study that assesses patterns of documented AUD across intersectional groups based on race, ethnicity, and sex in primary care when adjusting for the alcohol consumption measured by the AUDIT-C, as well as the DSM-5 AUD symptoms measured by the Alcohol Symptom Checklist. And so again, kind of like what I just mentioned before, in terms of the disparities or the differences existing even after you address or make adjustment for the alcohol consumption. Previous studies show differences in provider documented AUD and EHRs based on the intersectional identities, even after adjustment for alcohol consumption through the AUDIT-C screening. And so with the recent development of the Alcohol Symptom Checklist, unique to KPWA, we aim to understand how this additional adjustment might impact intersectional disparities when you can measure symptoms as well as some severity in the AUD diagnosis found in other studies. And so our sample included 14,442 adult patients, primary care patients at KPWA, who were identified as having high-risk drinking between March 2015 and February 2022. To qualify as high risk, again, these patients had to have an AUDIT-C score ranging from 7 to 12, which made up a very small percentage of overall screening population, which is 2.4%. And each patient completed the alcohol symptom checklist, and their race and ethnicity were documented in 4 categories: Asian, Black, Latina, and white. And the reason why, even though this population is so small at 2.4%, why it's important to do research in this area is because when working in a real world care setting, the resources are very limited. And so oftentimes a best approach or a good approach is to focus the resources on the most at-risk part of the population, and particularly when you're talking about substance use and alcohol use disorder. And that is part of the reason why you wanted to see do research within a high-risk drinking population. And again, our main outcome was to assess provider documented diagnosis of alcohol use disorder using based on ICD codes. Our predictive variable is a composite variable that represents 8 intersectional subgroups. And we have women and men from Asian, Black, Latina, and white racial and ethnic groups. Our covariates include the AUDIT-C as well as the alcohol symptom checklist. And again, that's the AUDIT-C scores in the study range from 7 to 12, because this is our high-risk drinking group, as well as the alcohol symptoms checklist score ranging from 0 to 11, which measures the AUD symptoms. Analysis were again conducted at the patient level. We described the demographic and clinical characteristics overall and across racial and ethnic subgroups. We use logistic regression to estimate the association of intersectional subgroups to predictor and the provider documented AUD outcome. We use a proportionally weighted marginal standardization procedure to estimate the prevalence and 95% confidence intervals of provider documented AUD for each subgroup. And so here again is a table 1 for our AIM-2. And just to orient you to the table, at the top, we have our racial and ethnic groups. And on the vertical side, we have, we see our characteristics, particularly the AUDIT-C, as well as the alcohol symptom checklist. And it is categorized in those different categories that we kind of mentioned earlier in the presentation. And again, white patients made up an overwhelming majority of the sample at 80%. However, we still have high ends for the other samples, and also tend to be slightly older. And men made up the majority of the sample, although the sex distribution is more balanced amongst Black patients, which is 41.9% for women and 58.1% for Black men. And lastly, Black patients had a high proportion of severely high alcohol consumption, as measured by the AUDIT-C score of 9 to 12 than the other racial and ethnic groups, as well as severely high AUD symptoms measured by the 6 to 11, and it's slightly higher than the other racial and ethnic groups. And so now we're on our main model, which shows the prevalence of provider documented AUD and the confidence intervals among primary care patients reporting high-risk drinking. And at the top, you'll see that we use a stepped approach. And so model 1 was unadjusted, model 2 adjusted for alcohol consumption, and model 3 adjusted for both alcohol consumption as well as the AUD symptoms. And if you can see here, it's like, if you look across the sexes for women and men in each of these models, the difference in provider documented AUD were observable up until you measure adjusted for both alcohol consumption and AUD symptoms. Yeah, indicated by the black box. Across race and ethnicity, provider documented, again, appeared consistently low in Asian patients in all 3 of the models compared to other racial and ethnic groups. Across intersectional identities, the adjustment model showed that provider documented AUD differed, ranging from 12.2% in Asian men to 21.7% in Black women. The model adjusting for alcohol consumption alone showed that the provider documented AUD differed as well, and it ranged from 11.1% in Asian men to 20.2% in white women. And the model adjusting for both alcohol consumption and AUD symptoms showed that provider documented AUD differed, but the range was substantially reduced, ranging from 11.0% in Asian men to 15.1% in white men. And also note that the intersectional subgroup with the highest prevalence of documented AUD also changed. And so overall, we see an attenuation of provider documented AUD as we adjust for both the alcohol consumption and the AUD symptoms. And we also performed a stratified analysis, which is not shown on this presentation, by both the AUDIT-C as well as the AUD symptoms, and found that the observable differences in the provider documented AUD were no longer visible. And this could indicate that among patients with the same level of both alcohol consumption and AUD symptoms, the intersectional differences in the AUD diagnosis may be less apparent. Now, this could be because of 1 or 2 things, amongst, of course, other things, but some of the differences in the AUD diagnosis found in prior studies may be due to differences in symptom severity. And our study, when we adjusted for the AUD symptom severity, we adjusted away the AUD symptom severity. Alternative, the physicians may be more aware of these screening tools, and that could have changed diagnosing patterns. In finance, we always mention that whatever you track, you are better able to account for the budget. So I think some of that same philosophy could also be happening here, where now that you're tracking the consumption as well as the symptoms, you're more likely to equitably diagnose patients. And so we have some limitations for this aim as well. And the cross-sectional study could not distinguish between whether we adjusted away the AUD symptom severity or physicians' awareness of the screening tool changed diagnosing patterns. And so future studies will have to elucidate those findings. Also, again, Kaiser Permanente, Washington is in the northwest part of the United States and has majority insured and white population. And again, also, it may be not generalizable to the prior studies I mentioned at the beginning of this aim that took place in the Veterans Affairs or VA, because the population is different. That population often faces active military conflict and has substance use programs in place, in large part because of that, and has a patient population that may be more likely to report alcohol consumption. Some key findings for this aim is AUD diagnosis was correlated with higher consumption and AUD symptom count. So the higher your consumption, the higher your symptom count, the more likely you are to be diagnosed with AUD. Disparities were observed across intersectional identities in the models. that were unadjusted and adjusted for alcohol consumption alone, just like prior studies, but less pronounced after additionally adjusting for the DSM-5 AUD symptoms via the Alcohol Symptom Checklist. And when stratifying by the Alcohol AUDIT-C as well as the Alcohol Symptom Checklist, observable differences were also attenuated. And some implications for AIM-2 is using standardized DSM-5 assessment may be one factor that reduces diagnostic disparities found in prior studies. And then additionally, another implication is tools like the AUDIT-C as well as the Alcohol Symptom Checklist may support equitable, accurate diagnosis across varying patient demographics by providing a standardized way for providers to assess AUD. And by providing this equitable diagnosis, we can also get one step closer to ensuring equitable treatment of AUD diagnosis. And so here are our references. And finally, we have time for a question and answer.
Awesome. Thank you so much, Rob. This was great. You can put in questions in the chat, or you can raise your hand and I can call on you, whatever you prefer. So we have a nice 15 minutes for discussion. I had one to get us started, and then I'll see what else comes in the chat. And your hands looks like Monica will be up next. I was curious if you could talk about the, which I think you alluded to, but the future of intersectional research or intersectionality research with EHR data, just to give people a sense of how important it is to be so detailed and to tease apart some of the, obviously a lot of things are hidden, and sort of just a comment or two about where you want to go next, or sort of how you think this kind of method can really maybe change the way in which we might do broader health services research. I'd love to hear your unfiltered thoughts about that, Rob.
Well, thank you for that question. I feel like the wave of the future is probably going to be in getting more granular in the way we look at people and patients in general, and particularly when we're talking about substance use and alcohol use disorder and more stigmatized conditions, because it gets you to a point where you can kind of cater to unique communities and kind of cater to what they may be personally struggling with by doing so. And so some ways in which we can kind of like get more granular in our studies is advancing the methods. Some of the methods include like the MITRE method, which allows you to place a patient inside of a pre-created intersectional identity that kind of mimics what the reality of life is. Some also, what I'm hoping we can kind of get to in terms of EHR data is having the EHR data reflect real questions that kind of surround racism, sexism, and social classism, the things that we ultimately want to kind of measure versus the proxies in which we use to measure those things. And I think using all of those type of tools and using that type of thought process of how can we get more granular and how can we get more specific to racism, sexism, and social classism and all the other isms in which we hope to address, I think that'll light the pathway for getting more specific and actually creating greater change regarding EHR work as well as health research work as well as like substance use as well.
That's great. I think I could go on and on about that, but I think others might want to build on that. Monica, did you want to come off mute and ask your question?
Yes, hi, this is Monica. I had 3 questions. One was that, was there any thought given to including spoken language, as one of the ways of identifying what diaspora this population might be representing? The second question was the reliability of your social variables in this data. I have never worked with Kaiser Permanente data, but the other data sets I have worked with have been very messy in terms of conflicting race and ethnicity. So my question is this patient-reported race or someone else reported the race? And the other part that I'm actually trying to understand is that given that you said that this is a stigmatized condition, whether you looked at other ICD-10 codes that could potentially point to AUD, but not state AUD, but would be less stigmatized. Because I'm trying to understand that while I'm all for standardized tools of detection, your method doesn't seem to say how do you get rid of the stigma. And so if there is stigma, there will be disparities. I just don't know if the standardization is going to resolve that. So whether there was any ways of addressing stigmatization by having other codes that don't explicitly say AUD because of various social implications.
Okay, thank you. Thank you for those some great questions. Language. Okay, so I did think about language in terms of thinking about, is that a way to kind of like look at identities or look at people? And so when we was thinking about a way to, I guess, do the methods, we kind of broke it up into, you see 18 boxes, and then it turned to, guess what, 32 boxes, 30, so it's like a number of boxes. So in order to really think about how can we explain the results, we couldn't necessarily include language in this particular methods and models, because it would increase the number of boxes, it increased the number of identities into a point where we couldn't necessarily explain it or in our results. And so that's why I was talking about earlier when Courtney asked her question, is a more advanced modeling, which is MIDA and a host of other modeling, which will allow us to kind of go to that level. And so, yes, I think that answers I try to answer, hope it answers your first question. In terms of the data set itself at Kaiser Permanente, Washington, in terms of race ethnicity, yeah, it was self-reported because of, I guess, the KP system in which how they kind of go about doing it. I can't exactly remember. I think what they do is on your first visit, you kind of explain, you kind of fill out a form, and then that's the way you self-report it. And then if not, then you go through your EHR system, and then you update it yourself. Now, of course, there's always going to be some discrepancies in that, but from what I've understood, for the most part, it is self-reported. And your last question, in terms of what is stigmatized ICD codes, and it's always going to be a stigma in terms of the standardized procedure. For the most part, I think these methods and these standardized procedures, they help, but ultimately, I do believe that it's going to be well, I guess we're not necessarily even going to be accurate until we start addressing racism and sexism and things of that nature in the first place. By nature, these are still going to be proxy variables. And so I think just getting down to the granular thing. And also, I am currently working on a study that even takes it further than the ICD codes. It's actually looking at the descriptors in which you use in order to even be able to diagnose someone with an ICD code of AUD in the first place. And so what that allows us to do is even get more granular, even beyond the ICD codes, and see, okay, what type of language, and what is the language itself stigmatizing? And so there are thoughts that can kind of like help us expand beyond the ICD codes. Hope that answers your question.
Yeah, that's great, Rob. In terms of the race ethnicity variables, to build on that, since I've worked with the Kaiser data versus a lot of other EHR data, yeah, it's much better data. It's not perfect data, but it's much better data because of their proactive approach to reclassify people based on race ethnicity. They had a whole process of doing that. So even in current patients, they went back and called every single patient to have them self-report to fix any errors in their data. So it looks a lot better than a lot of other EHR data that I've seen. That's one thing I wanted to say. And then the stigma question, yeah, I would love to. I don't know if anyone else has a question. Please do. Oh, I see one in the chat, actually. Sorry, I'll come to that in 1 second. The stigma question is really interesting. I want to wrap one more sentence or two about that, which is that this idea that I think what Monica's getting at is like doctors not wanting to use or patients asking the doctor not to use an AUD diagnosis code because they don't want to be stigma, like this idea that that itself has some differences across. So there's the stigma that we bring to our in our own life, and then there's the I know this is stigmatized and I don't want it attached to me kind of thing. Do you think I think it's difficult to do using administrative data, but I think is there any other final thoughts on that piece of it?
Yeah, actually, that was like part of the thought process for even doing the study in the first place. Particularly because we know that majority of physicians are white. And so, for example, say if you are a Black person, you're less likely to be able to negotiate not even having that diagnosis being a part of your EHR in the first place. And so even that kind of gets to the ultimate level of disparity that exists depending on one's racial, or you know what I'm saying, for a lot of times, because you even think about like historically or even like in terms of society, alcohol use has, I guess I would say historically in society, been a male thing that happens. And so a lot of times physicians may not even ask women in the first place, do you even consume alcohol? Maybe not even engage in those type of conversations. And so there exists in it on even on both sides versus underdiagnosis versus overdiagnosis, a sense of disparity based off of, like I said, just racism, sexism, and things of historical importance.
Yeah. And I think it's interesting when you break apart your data because of people who score high, if they did get scored on the AUDIT-C and they did report the data, which some people could decline or the doctor doesn't give it to them or a variety of other processes, then there's still differences of how they would document it, right, in the note, which to me, so just trying to use your sampling to try to get into the more precision about what's happening. But I don't think anything will be perfect, Monica, just to add my 2 cents, right? Because there's lots of things happening and it's like, how granular are we about how we think about it? Rather, which I think in the previous way of doing health services research, at least how I was trained, was to adjust away for all of these factors and to think about them maybe or just look at race, ethnicity, and then to adjust for socioeconomic status or whatever it may be. And I think what Rob's helping me think through is ways of getting more granular, understanding that we'll never be perfect in our, because it's not the real part of what people's experiences are, but getting us closer to something where we can use it for more action and get more precise about it. I think that's where my head is thinking about other applications of the kind of method that you're talking about, Rob. And then I have one question in the chat, and then I think we'd have time for one more if anybody else wants to raise their hand and write in the chat, which is really about the new Surgeon General report and this idea that we're going to have more attention potentially in the US about alcohol consumption. The specific evidence was cancer related, I think breast cancer related in particular. Do you have any thoughts about sort of this new attention on alcohol use or this associations with cancer is Jeff's question in the chat.
Thank you, Jeff. I think that's a great, well, I think it's good for overall awareness of alcohol use disorder. And as alcohol consumption continues to increase, I think it definitely leads to more problems in other areas, as well as the overall disparities between women consumption as well as male consumption. As that kind of decreases, well, it'll create greater problems down the line. And so anything that can bring awareness to alcohol use disorder, I love it.
I love that. Yeah, it's been kind of a hidden thing. The other thing that's coming out a lot is that J-shaped curve of that a little bit of alcohol is good for you, but then a lot is bad for you. And how we all are sort of now agreeing that that's not actually the case. But even 10, 15 years ago, when I was learning about this research, there was that assumption, that's from grapes, wine, or and so trying to dispel what that looks like. And I actually think fits into your topic of stigma and some other things too about how people self-report. There was this holding on to certain thing about alcohol and trying to be more honest. In Europe, they've been doing this differently for a long time, and how the US will compare to how we think about it in other countries. So those are my editorial comments. Yeah, this is the CME credit again, since it's new. We're putting it up up on the screen one more time. I think we're almost at time, so I think I'll wrap it up here. just really want to thank Rob for your thoroughness and your detailed presentation today, to teach all of us about potentially a new method and applied specifically to the use case of alcohol use disorder. Everyone, I think, knows how to find you, especially those of us at UC Davis. But if you need to get in touch with Rob or have questions for him, I'm assuming he'll be available via email if there's any follow-up things. But thank you all. Yeah, I volunteered you, but I knew you would say yes. But yeah, thank you all for joining us today for our first session of the winter quarter. We have a great lineup for the rest of the quarter if you haven't seen it on our website, and we hope to see you in future weeks. Thank you all. Happy New Year.
Thank you all.